Thank you so much for the invite today to present on AI and AOD and social services. As my intro said, I'm the director for the CSIRO Next Generation of Graduates Program in AI and Mental Health as one of my many hats. And as part of that, we're working with lots of different organizations, but Turning Point is one of our primary collaborators on that. So this program is funding PhD scholarships for really targeted work in the mental health sector with 4 PhD students. I'll name Isabel, Liam, Lax, and who am I missing? Arisha, of course, and Arisha. And they're all doing wonderful things. And we have 2 of the supervisors in the room as well. So hello to the extended network. Fantastic. So I'll be, I'm going to present this talk quite positively, and I'm aware that there might be different opinions about AI in the room. And one thing that I will say is that I'm not an AI head, really. So I trained originally as a speech and language therapist. So I'm a clinician at heart. And I've been working in the field of human-computer interaction for well over a decade. Well, it's probably moving closer into the 15 to closer to 20-year mark now. So yeah, I very much come at it from a human-centered, co-design-led kind of angle. So if you have any technical questions, I probably won't be able to answer them, but I can pass you on to people who do. So just as a bit of engagement, because it is the end of the day, who in the room, just from a show of hands, is actively using AI? It's everybody. And put your hand up if you're using it to support your work. Oh, a lot of people. And put a hand up if you're using it to support clients. Oh, interesting. Nobody. Okay. All right. So, I mean, it's really clear AI is already in the room. All right, so it's not about what we're going to do with AI. It's how we're going to live with AI, really, in terms of supporting our work and potentially our care. But the important thing is, how we do it well. And if we're going to do it with clients, then how do we make sure that it's safe and trustworthy for them? I'm in a really awkward position.
There's a clicker up there.
Oh, fantastic! There we go. Okay, so I probably don't need to give you these stats because they've come from VADA's own survey, but there's, a challenge that we're holding here. So around 54% of the AOD workforce report working extended hours over time, and 52% of the workforce, of leavers from the workforce in the sector are reporting high stress and burnout. This is a real opportunity for kind of administrative work-led AI to really support people. And then only about a third of people who actually need support for AOD are actually receiving treatment. Again, another potential opportunity. Although there's caution around the potential of using it with clients, as you'll see as I discuss this talk, people are probably already using it themselves. All right. And now represents a really important opportunity for technology-mediated and particularly AI solutions. We've got really capable AI models, those language-based kind of ChatGPT type models and pattern-finding models that are actually good enough now to help to be genuinely useful and help inside real care workflows. And we're seeing this emerging within the literature across the healthcare sector, while it's not necessarily an AOD, across the healthcare sector in quite good use cases. The second is telehealth is becoming a lot more normalized. These kind of digital first remote opportunities for contact through digital technology is a lot more normalized. I wonder what could possibly have happened to make that begin to improve in 2020. Thank you, COVID-19. And then the third is that we have quite advanced data maturity now. We've got a lot of organizations across the sector who are collecting robust and structured data in quite standard ways. This makes a really useful data set for us to train AI models on if we do it very safely and ethically, of course. I'm not saying give up all your data and let us train models on it. That's not the point of the talk. When I say AI, everybody immediately thinks of ChatGPT. I guess, did you think of ChatGPT immediately when I said AI? Yeah, lots of heads nodding. But it's actually not a new concept. So we've had AI since the 50s with when Alan Turing released the Turing test. This was our first glimpse at artificial intelligence, where a machine was exhibiting a level of human intelligence. By the time we reached the 80s, we were developing learning models, machine learning models, that were able to very successfully do quite constrained tasks. And a good example of this is we have a lot of historical data from an emergency department, and we want to know what the patterns in that data are so that we know when to bring more staff on board. So the model could potentially look back and find those and answer very specific questions. It becomes a bit more complex with these kind of deep learning models. I'm not going to go into it too much, but it's kind of like a human brain in that you can give it so much, tons and tons and tons of information, and it will begin to develop the patterns, and it can learn from new data. So a really good example of this is that if I trained lots and lots of CT or MRI images looking at tumor boundaries for cancerous tumors. If I then have a patient who, the model has a lot of data to look at and learn from, and then if a new patient comes in and I give them a brand new picture that they've never seen before, they can potentially find tumor boundaries that an eye might not necessarily see. And again, a solid use case that is actually being implemented at the moment. Then we got Gen AI, which is our ChatGPT. And this is AI that's able to actually create brand new content that it's never seen before. But the point here about generative AI is that it's a baby in relation to AI. The first public release of ChatGPT from OpenAI was in 2022. So we're really only just starting to learn what this quite revolutionary technology is actually doing and how people are using it to support health and care. And it is happening. We just don't have the research to back it up. So just to quickly reset, because I'm aware that this is I'm probably waffling on a little bit. AI can support with pattern finding. It can have generative tools, so being able to give you generate case notes, answer questions. And then we can also develop these kind of purpose-built tools. Remember I was talking about that about that example where I'm giving it lots of CT or MRI images of brain tumors, for example. We can also do that with those kind of ChatGPT type tools. So let's say that I purpose build a generative AI, which is trained on all of the information and documentation that VADA has ever created. I can do that. And then if somebody speaks to a chatbot that I developed, they only get responses that are of relevance to those documents. Okay. So there is ways to do it safely. But the important thing is it's not about replacing the clinician or the practitioners at any point. They're supposed to be assistive tools. And I specifically kept this image in, but there is a mistake in it. And that's why I specifically kept it in, because it shows some of the challenges with the generative tools. So if you see the last node of my umbrella, it's supposed to be generative AI, and it's AI. This is an example of when AI gets it wrong, and this happens really frequently, especially in this image generation space. But I'll cover that a little bit further in some of the challenges. So on to some of the potentials, the opportunities that we are seeing in the literature in these kind of clinical use cases. So the first one is more centered around prediction of risk, or the triaging of patients based on clients, I should say, based on their risk. So the example here is if a client was coming to access the service, they're responding to some questions through a chatbot, for example, or they're doing a digital screening tool, and then there's a level of risk prediction that's happening there, which is helping triage them for to be picked up first if they're the highest risk before they get to crisis, and maybe lower level risk being seen to in a slightly different way. That's a lot of work is going on in that space at the moment. So this is all about kind of light touch screening or light touch kind of interactions with an AI technology, so that the AI can then pick up signals that somebody might potentially miss, and can help in terms of risk, and then can help the client, the clinician, to engage in that conversation. But it very much has the clinician in the loop there. The second is then still kind of centered in this prediction space, but it's more solidly around preventing relapse. And this is probably one of the, there's a significant literature base in this type of space, especially in AOD, and it's got quite significant clinical promise, but there are big challenges with this and the amount of information that it captures about a person. So, there's quite a bit of work that's centered around the use of things like wearables, check-ins that people might do through their phone, the use of sensors on somebody's mobile phone. There's actually a lot of information that can be captured. Things like their sleep, how many contacts they've had in a day. And this paints a bit of a behavioral picture of a person in those moments between clinical sessions. The models can be trained then to look at what potentially is different from that person. And when we're looking at mental health prediction in that way, it can find quite nuanced differences and changes in a person's pattern of behavior that might indicate a relapse is about to begin. There's a lot of work in this space also in kind of the eating disorder space, my own work included, as well as in AOD and bipolar and psychosis. This, for me, is much more centered around an individual and them having control over this. So some of the work, it's just the person who gets that kind of nudge. Something might be going on here. Maybe you should reach out to your clinician. Personally, for me, that's probably the way that it should go, because this is so invasive, this type of data capture. And then there's other work where it kind of links into a clinician dashboard and they can monitor those kind of risks. But I think the main thing here is, most people don't want to capture all that information about themselves. So while it's a useful use case, we need to think about the person at the other end and the fact that, they probably don't want you surveilling every element of their life. And then, of course, there's that 24/7 support tool, the chatbot or support tools that somebody can engage with between their sessions when the clinician is no longer available for them to reach out to, for example. So these can help with, providing information or kind of lightweight support for those at lower risks. Give handoffs to clinical services when they're needed and that kind of risk levels or crisis emergence is a little bit higher. And then also provide some of that continuity of care that we need. So, the reminders, the check-ins, the kind of coping tools or strategies that the person has come up with in their sessions to help support them in those moments between clinical care. Okay, so that's kind of the client side of things. Now it's on to you as workers, really. So a really great opportunity for AI in the space, as everybody has already put their hand up and said that they're using it, and a lot of people are already using it for work. It's given time back to people, given time back to practitioners, so they can spend more time doing what they actually enjoy doing, which is usually the client to face-to-face contact, that direct care that they're providing. And actually, it did come up in the survey as well, the Nevada survey, that is what keeps people in the profession. So we want to give people that as much as possible. Doing all that documentation and administration eats into that time. So AI is a really useful kind of support tool to give you back some of that time. there's two little logos there on the screen. You might have heard of Heidi. Has anybody heard of Heidi? Yeah? Which is like an AI scribing tool. So it'll listen to a session, automatically transcribe what's been said, and then summarize those case notes for you. Doing a lot of work on your behalf. So Heidi's been really widely rolled out at the moment across multiple kind of different large-scale hospitals in Melbourne. And then we have smaller organisations like Practiluma, which is an AI-powered kind of workspace, which is specifically designed for the mental health sector. I just wanted to plug them ever so slightly. They also have an AI scribe. So these types of scribing tools can auto-draft notes for you, give you session summaries, but it's very important to remember that they must be reviewed, of course, and shouldn't just be thrown out there. The other possibility then is when you have something like a practice management software, which has AI running in the background, is that it can pre-populate lots of forms. You know those forms that you're sitting and you're typing the same thing over and over and over and over again into the forms? The pre-population of forms using AI tools, again, is a really great time saver. And it's, of course, giving you back that face-to-face time with clients. The data here is somewhat illustrative because it's on care practitioners more broadly in a US study. But the University of Wisconsin did a couple of different RCTs actually, and are now doing wide-scale rollout of AI scribes, where they measured the amount of time people were spending on admin before and after the introduction of the AI scribing tool. It's quite a modest reduction. It was about 30 minutes a day people said that they saved. But again, remember, absolute baby in the sector. You know, we're only a couple of years into these. Imagine what that could be in, 5 years' time as functionality improves. So the main thing here is that AI can't do a lot of the things that a human can do, and we need to make sure that when we're integrating AI that it's being used as this type of co-pilot to the work that we're doing. Humans have empathy and trust, and AI might look like it has empathy and gain trust, but it's not really capable of that. We can build relationships, we can build rapport. We have clinical judgment that an AI can't possibly have unless it's very, very, very well trained, very well tested. The context and the nuance of the entire person's kind of background and the clinical expertise that you bring to understand that context and nuance around a client's case is, again, something that an AI can't have. And of course, the buck kind of stops with the practitioners. So we have accountability. AI then can, do work at scale. It has recall that we potentially, can't hold in our brain, can spot these patterns, can give us drafts and summaries, and is, of course, always available. I'm going to have to take a sip of water, excuse me. Okay. So we talked about some really great opportunities. It's time for some challenges because I love a balance. I'm particularly talking about generative AI. This is our ChatGPT or Claude, not AIs that have been kind of specifically trained. And the reason I say that these are to be mindful of in practice is because a lot of your clients might actually be using AI already. And when they're coming to you, they have some level of idea in their mind, as well as your own use of AI tools. So our first challenge is what we call sycophancy, and that's that these AI tools always agree. They always agree, no matter what. They always agree with you. These models are trained to be helpful, the general purpose models. I'm talking about ChatGPT and Claude here, Gemini, whatever it is that you use. They're trained to be helpful, and they're trained to please you because they want you to come back and engage with them. They don't want you to go into another model. It's a bit like the social media algorithms that funnel you content, even if that content is particularly toxic, because it wants you to come back and engage. So it will agree with you, it'll flatter you, and it'll tell you, for the most part, what you want to hear. But this is not always helpful. So, of course, if clients are having this level of agreement all the time, it can reinforce, harmful plans, minimize risks, and, of course, skip the hard truths that a real person would tell you. The other thing to say here is that it's never silent. It gives you instant response. An instant response that always agrees, that always validates. It's a very different experience speaking to a human. And it doesn't have a therapeutic frame, so there's no duty of care built in, there's no challenging of thoughts, no accountability, and it provides comfort instantly without change. And I guess we want to put ourselves in people's shoes here, and that is great for a lot of people with low-level problems, but it's just worth us being mindful from an AI literacy perspective. AI-induced psychosis is a kind of newly formed clinical concern, a new phenomenon that's beginning to appear in the literature. And this is kind of a ramped up version of sycophancy, in that people who are really heavily engaging with the chatbot like ChatGPT, but also with kind of more relational AIs like, there are two, Character AI and Replica, are both little kind of avatars, like a real person, and it will chat to you like you're chatting on WhatsApp, back and forth, short messages. And it's very much built for relationships. I think the tagline is an AI you can be yourself with, an AI you can learn to love, an AI you can whatever, and that's on the website as you sign up. So the AI-induced psychosis is again the reinforcement of delusional or grandiose thinking in particularly vulnerable people. It's always on. It's constantly echoing the thoughts and amplifying those distorted beliefs instead of challenging them. And of course, this is particularly challenging for vulnerable people who are isolated or in crisis, or of course predisposed to psychosis. And then I alluded to this earlier with my image of the umbrella. There's also this thing called hallucination. And this is when the AI will give you a fully confident but wrong answer, either a little bit wrong or very, very wrong. Has anybody had an answer where they've been like, that's not right? Yeah. These are hallucinations. Because again, it's not actually a person. So, it's picking up lots of different information sources, it's pulling them all together. It's basically just trained on the internet, and we all know that there's not always fantastic stuff on the internet at all points in time. But it doesn't distinguish between something from the World Health Organization and something from, Joe Blogg's blog. It's just pulling all the information that it can together. So sometimes it will give you completely made-up facts, and this becomes challenging when, for example, a client's due to, we had a fantastic panel. We've just had a really, really great panel talking about stigma, and I'm sure that you can all imagine a client feeling stigma, not wanting to reach out and turning to something like this to seek help as a first point of call for their AOD challenge. So, if a client actually gets wrong information about things like withdrawal or dosing or crisis advice, then this could be potentially quite dangerous. So it's not something I've seen in the literature yet, but I think it's an emerging challenge that we need to be actually actively mindful of. The reason this hallucination thing, people get caught out with these hallucinations as well, it's worth bringing up, is people will use these AI systems for really low-risk problems. So I might ask it to help me find somewhere to go on holiday. This is something I did recently, actually. Where to go on holiday, this is my budget, I've got a toddler, and it's given me fantastic, brilliant things. I actually did book one that I found on ChatGPT. It's great. then you might, get it to help you draft a document for work. You're kind of raising the stakes somewhat. It's a little bit more important. And then when it's confidently giving you things that you're happy with, you build that level of trust in the AI. So then you start asking it a little bit more personal questions. And then, you get into basically a rapport and a relationship with the AI tool, which is just an off-the-shelf tool to answer general kind of questions and help with tasks. From our perspective as professionals, then, we need to be really, really careful as well that we're definitely proofreading everything that comes out of an AI, because if you submit something to a client, like case notes to a client, and there's errors in there or misrepresentations in there, it's going to erode trust. I'm rapidly coming up to, how long have I got?
3 minutes.
3 minutes?
No, I will be on for now. 7 minutes.
7 minutes. I will get there, I promise. The last one I've alluded to. So Dr. GPT, we used to have Dr. Google that would plague GPs. People would Google their symptoms, they'd come in, they talk about what they'd seen, they have a sore head and suddenly they've got either brain cancer or something else terrible. Now people are using Dr. GPT, and again, it's given that very confident responses. So if somebody's late, I again perceive that we're, perceive's not the right word, what's the, anticipate that we're going to see these challenges emerge more, because we're seeing these challenges across the mental health sector more broadly. So clients are leaning on AI as a makeshift therapist. Potentially they're kind of testing the waters in terms of what the advice might be before they're reaching out for support, but sometimes they're just using it as the support as well. So if this appears in practice, I think the thing to remember is that there are reasons that they've approached an AI before coming in for support, and they might actually be getting something out of this that's positive for them. So again, that's something that is available 24/7, that they can talk to, that they can go back and forth with. Maybe they need a level of validation at some, in that time. But it's really important to be curious about their use and not kind of become alarmed and try and remove it, especially with those more kind of relational character AI type approaches. But we can, now that we've done this talk and all the challenges with it, you can start to name some of those gaps for them, and have make it very clear that there's no kind of accountability or duty of care, or if there's crisis, they will need some kind of a safety plan. And of course, bring the thing that we can bring, that only we can bring, which is that kind of relationship element and that building of a relationship. It's future-facing challenges that are being anticipated, but we also need to be mindful of the potential changes that this could make in practice. So if we have people who are reaching out to an AI that is, as I said, constantly validating, answering immediately every single time, that could potentially change their expectation of care in the near future. So it's something that we really need to think carefully about and be mindful of. All right, final thoughts. I want to end on a positive note, because I do believe that AI is quite revolutionary, and we're at a really excellent time for it now, and I'm a proponent for it. I think if we do it safely and we co-design it with people and ensure that it's equitable and non-biased, it'd be fantastic. But there's a lot of steps to do that well. So it's only a good opportunity for society if we do it well and it reaches everyone and can be a trusted resource. I'm not going to dig too deep into this. I think you can see them here. The only one that I'd really touch on is from a practice-based perspective, excuse me, is privacy and consent. So if you are going to use AI scribing tools, have a chat with your clients and make sure that they understand where the data is going, how it's being used, what's happening, the fact that, their data is going in to retrain an AI model and is being held by an organization. We really desperately need good plain language explainers for patients and clients about the use of AI in practice. And then the other thing is, try and understand where how the tool is being trained. Because if we're training something on the experiences or data of 5 million 30 to 35-year-old straight white men, then that's going to be very different for people from diverse backgrounds and what they might experience with the AI. And then, just to finish off, I think that we really have a lot of opportunity here for the future. So we can have care that reaches further, practitioners who are, hopefully a little less burned out because they can spend their time doing the type of work that they love. But we need to be really ensure that we're developing trusted content and products. And if you want to put it into your practice, you want to start small, stay curious, and keep the person at the center. So, pick a single workflow, run a small pilot to see whether it works, whether it's appropriate for your context, and ensure that you're bringing people with lived experience into those discussions if you're using a tool with them to co-design those solutions. In terms of, actually, no, I'll just stop there. I could chat for ages. All right.